Hello, everyone. I know this is what you've been waiting for. Interview with Dr. Grotas, who is from New York Urology. He started using virtual scribes just about 5 months ago. I interviewed him, as a matter of fact, around the turn of the new year, actually. And if you missed that interview, please check it out. And I'll link it in the video description. I am here. I want to find out what what his experience has been since he went live with the virtual scribe. We discussed his initial experience before, but I wanted to hear what is going on now. So welcome to the program, Dr. Grotas.
Hi, John. Thanks for having me. It's really a pleasure to talk to you tonight, and thankfully I'm healthy and you're healthy. And I think that there are a lot of things that I learned when I started having a virtual scribe.
Aaron, before you start, Aaron, before you start, I'm going to encourage everyone with questions to go ahead and leave them in the comments. Sorry to interrupt you. And if you don't mind giving the audience a little bit of a 30-second summary of how your practice is set up at New York Urology.
Okay, so I have a private practice where I'm the only doctor. We have a receptionist, an office manager, and 2 medical assistants. So basically, I was doing a lot of the computer typing and secretarial work for myself and using some macros and templates with my EHR. And I really enjoyed your interview about Dragon and all that stuff. That was a great way to automate. And I think that automation via virtual scribe is another great option. Especially for people who are maybe a little afraid of using macros or want to have a dialogue as they work on their program. And as your expert talked about, who sets up the Dragon system, it's really that training that helps put everything together. And my scribe and I work together all day, every day. I'm in my private office, and we're constantly improving the workflow. And I know somebody commented on a post in New York the Thriving Urology practice today, saying that their providers are all very computer competent and internet savvy. I'm 43 years old, and I'm very internet savvy. I type 60 plus words a minute, maybe not as fast as you, but I can hang in there and type exactly what someone's saying as they're saying it and talk to them when I'm seeing a patient. So that's not really the issue. I think part of it is that as a physician, I want to be talking to patients face to face like we're talking now. And I don't want to be typing, and I don't want to be a secretary. So I think that Hello Rache is an option for some people. It's not for everybody. But when Kelly Casperson was talking about it on this channel, I was like, hey, I got a couple of targeted Facebook ads to me about it. And I said, well, maybe now that I saw Kelly likes it, and I actually went offline with her and asked her a couple of questions about it. I said, I'll give it a shot. And there really is, there's no down payment. There's no major commitment. And even now I can terminate the relationship tomorrow and have no penalties or no ongoing costs, as opposed to trying a new EHR or having a contract even with a Dragon provider or something. There are some big fixed costs sometimes. And as urologists, I think we really embrace when there's variable costs rather than fixed costs, because a urolift is a very expensive procedure. You're taking some risk, but you really didn't have to put a lot of cash up front to a urolift system. So for a busy provider to ramp up production, when you scale up in your urolift business, you don't have to scale up too much in terms of how much more resources you need to do those extra procedures. And it's a lot of appeal to most urologists.
Yeah, some scalability. So you covered a lot of things in the in the first tranche of dialogue. Gosh, okay. You mentioned Hello Rache, which is the platform, the virtual scribe platform that you used, and you started using back in January. You also mentioned that some of us can type very quickly, and I certainly can type around your speed, 70, 80 words a minute. And as a matter of fact, I actually was a secretary. I was an administrative assistant to a female entertainment business manager, and we manage rock bands and actors and actresses, and I worked in Beverly Hills. So she literally dictated to me, and I typed as she dictated. Not only did I type, I corrected her grammar as I typed the letters. So I took verbal dictation. So I know how it is laborious, and I know how it's like on the receiving end. And I agree. You're 42, and I'm going to be 55 this year. And as you know, I'm running this whole show. I love computers. I'm very tech savvy, but not everyone's tech savvy. And also not everyone wants to spend the time and energy to do the typing or the data entry, if you will. Not everyone likes to want to spend the time and effort to figure out Dragon. So for those people, maybe virtual assistant is the way to go. Now, as opposed to a real life assistant, it's definitely a lot cheaper using a virtual assistant. And Dr. Gabal asked, what is the hourly cost for the Scribe? So why don't you discuss the hourly cost and also how much time commitment is required from your end so that you have a consistent Scribe that is assigned to you?
Great. So they have a fixed cost currently. It's $9 an hour. You pay by credit card. I have a specific business agreement with the company, and all of this assistants. And they don't have to be a scribe. They can do other stuff as well, which I can talk to you about. What we did when we pivoted towards telemedicine in the office. They're there for you to help you, and as long as they feel comfortable doing what you ask them to do, they can make phone calls. They can book telemedicine visits. They can. My scribe, Shasha, she also helps me with some social media outreach and information packets, doing things on Canva and other platforms to sort of reach my patients. We've done some descriptive videos.
So this is not just a scribe. This is a virtual assistant who does not just the clinical documentation. She's helping you with other stuff. It's like a personal assistant.
Right. No, it's a personal assistant, and also a lot of practices, they started calling patients who hadn't been there in a while to get some telemedicine visits to let them know, hey, we're here. We can still see you even if it's virtually. So she was able to help me with that, with some of that outreach, making phone calls and sending emails and texts to patients in a HIPAA compliant way.
That's smart. That's really smart. And how much?
The other thing,
how much time does? What is the time commitment required on your end so that you get to keep that one person? Because sometimes you if you don't commit to this one person a set number of hours, you don't get to keep her all the time.
Right. I'm pretty sure in the beginning it was 20, and I think they were looking for about 30 hours a week at a minimum. You don't need to have them for 40 or 50 hours a week, but I think you do need a full 30 that they're looking for.
It is so inexpensive if you think about it.
I see all the bills, and it's some of the best money I spend during the week. If you think about it, when somebody is working from home, they're much less likely to call in sick. They're much less likely to not be available during the work hours, even if their kids are around or there's a problem. So because of that, the versatility of having a utility player or someone who can pinch hit to answer phones. We have a Google Voice number, so a number comes from our same area code. We had some glitches with Doximity, where Doximity was not available in the Philippines for use. Sometimes we could log on from there, but it wouldn't really work too well. So that was one of the glitches we've had. But overall, it's been a pleasure because even though I don't mind typing up things and making a note here or there, I'm much happier to go see the next patient and make phone calls to patients and be more available to my staff that's there in person to interact with them more, because I'm not in front of the laptop or in front of the desktop as much during the day. when I'm seeing patients in real life.
It certainly frees up your time. And Dr. Casperson and I were talking, and she mentioned that having that virtual scribe has given her the opportunity to start a podcast. So her podcast is You're Not Broken. So she's now found time to explore other aspects of her life that she wants to pursue, a passion of some sort. So having somebody doing the work to free up your time so you can pursue your own passions and just make your life easier. I think it's definitely worth it for that small amount. Those who are watching, please feel free to leave any questions in the comments, and I will try to ask Dr. Grotas to answer them. Sarah asked, do you get someone urology specific? So why don't you briefly kind of give us a recap on how you picked your scribe from the Philippines via Hello Rache and why you picked her. I know we covered that in your last
Sure.
interview.
I'll just say it real quick. So I picked Sasha because she was everybody whose videos I saw, they were either nurses or they had worked in let's say the administrative department of a radiology department or some other type of facilitative role in healthcare in the Philippines.
So this is kind of like during your selection. This is kind of like during your selection process when they gave you a bunch of choices. Okay.
Right. So everybody had HIPAA training. Everybody kind of knew some basic terminology. But I specifically did not pick the person who was a RN, a nurse. I picked someone who had the best speaking voice, had the most sort of neutral accent, so that I could have the versatility of having them physically or talk to the patients over the internet or on the telephone and act like an extension of my office, not just a typist. Because I really didn't need a typist. I needed someone else to be able to stay with me all the time to get my work done while the other people I were paying are talking on the phone to patients, checking patients in, doing these other tasks. And with telemedicine, she helps me a lot during telemedicine because she can start documenting what the conversation is while I'm having the conversation. If you and I were doing a telemedicine visit right now, and I have to capture your history of present illness and your meds and everything for a new visit, it's pretty arduous to do that and be present and be focused on the patient. Most of the platforms for telemedicine do not record the conversations. So you really have an opportunity right then and there to document what's going on. And I think that's a lot better for telemedicine because the requirements are not necessarily, a lot of people are billing on time, which you and I both do not agree with as the best way to go. Maybe for those phone check-in visits and stuff like that, but not for the 99213 or 99214 visit. You don't want to spend 45 minutes on the video visit for a 99214, not high yield for a provider.
No, billing based on time is an inefficient use of a urologist's time.
Sometimes sometimes you can resort to it because you actually did spend the time, and
and sometimes you have to when it comes to prostate cancer or bladder cancer or some other cancer diagnosis, and for which you're spending a lot of time at the end of the day or at the end of the afternoon or the morning block of time. So yeah, definitely.
Right. But I found that she's been helpful with that and been able to help coordinate with those visits as well, because people say, oh, well, I just text or WhatsApp my assistant to sort of close the loop. But if you have and I think that this is something that's kind of lacking in some of these telemedicine platforms. I was using Epic today because I work part-time for Mount Sinai Hospital and the medical school. And we were using a translator for Cantonese. And I had the Cantonese interpreter on a regular phone, not my cell phone, holding it up to the iPad so that they could hear each other. And I asked the interpreter who works for our hospital, can you log on to the visit with me?
Yeah.
And they said, no, we don't have that capacity.
Oh, that's terrible. Okay.
Yeah, it was really tough.
One of the best things I think about telemedicine is that I recently had a deaf person that I saw via telemedicine for a condition that was amenable for telemedicine. So we set up the translator and the patient. And I had them both on at the same time in a group visit. So all three of us are on, and it worked out beautifully because the patient was able to watch the American Sign Language by the translator. It was beautiful.
That's great. What platform did you use for that?
I'm using doxy.me.
And you're able to do a group visit
Oh, yeah.
through that?
Yeah, and I pay for the professional edition or whatever it is.
Of course.
Like you said, best money you spend, right? On virtual scribes, best $348 I'll spend on this platform. Higher definition video and stuff like that. So back to virtual scribes. You basically pick Sasha, is that right? Because she is much more fluent, and she doesn't sound like Philippines or overseas support, like when you call your electronic health records companies for support, right?
Right. And trust me, there was nothing wrong with any of the other candidates. I just wanted to make sure that when people heard a representative from my office on the phone, they weren't going to get suspicious that somebody's calling from an outside agency, that they're not really acting as an agent of my office, but from some third party. Even though she does work for Hello Rache and we only have a contract between us, she's really becoming part of the office fabric because she represents me and my brand out there in the world, both on social media and in in talking to my patients.
All right. Betsy says cost for Hello Rache is $9 per hour. Yes, that is correct. Okay, so you started about 4 or 5 months ago. What has your experience been since getting your virtual scribe?
I think the experience has been very positive. The notion that physicians burn out because they spend a lot of time at home documenting on their EHRs, doing their billing, is a real problem for most physicians. They're losing that pajama time, that time when they should be hanging out with their kids or their wife, which I'm kind of easing up on now, but that's okay. I mean, this is really fun and I like it. So I'm happy to be here.
And you're helping a lot of people. It's interesting how these interviews impact so many people.
It's my pleasure.
Yeah, you just don't know who you're impacting because they'll look at it, and then when we repeat the interview like this, doing a follow up, they may look at it and say, "Oh yeah, that now might be a good idea for me." And you are discussing things that no one can anticipate or can experience unless you've gone through it. So your experience is invaluable. So thank you for sharing. And those of you who are watching, please feel free to ask any questions in the comments. Sarah is asking, is there a minimum in the hours per day or week? And I think Aaron said, Dr. Grotas said that it may be 30 hours if you want to keep that same person with you. If you want a full-time employee, that virtual assistant, they require a minimum of 30 hours per week. However, you can, if I'm not mistaken, you can use it a la carte, but there's no guarantee that you'll have that same person with you.
Right. I think that if you're going to, so you don't have to, if you have 3 or 4 providers and they each want to use this virtual scribe one day a week, or they want to piecemeal, they don't have to be, per contract, it's only 30 hours, but they don't have to be doing virtual scribe the entire time. So if you're having problems, if you do your own AR, accounts receivable, in-house, and you need help with that, they're probably more than willing to do that as long as you have some type of tutorial or you tell them how you like things done. They could do a lot of different things, confirm appointments. They could arrange sort of, I kind of create a sort of a patchwork of things that are beyond the, let's say, 20-something hours of patient care that I provide in my private practice to bolster my practice and what I can do to grow things. So part of it is that, I'm going to be launching my own vasectomy website called Seedless New York. So it's very similar to the all juice, no seeds idea, but the idea is that we're providing for men in New York a good option for that they can come and feel comfortable and get a vasectomy. And I think now with telemedicine and people from around the state at least being very comfortable going online and meeting a doctor, I think that men will travel to come see me to get a vasectomy because I'm going to be out there and I'm going to be having my patients talk about how wonderful it is to make this life choice.
Yeah, sounds like a great idea. It's basically she's not just a clinical scribe; she's like we discussed, an assistant, and she could help with, like you mentioned, posting things on your social media platform. She could call on accounts receivable. She can help you with Canva, which is designing different posts for social media. So it's not just limited to just clinical documentation. And
Right.
while we're talking, I was wondering, I wonder if you can have one scribe assigned to two different physicians. That way you can really fill up his or her time for not just 30 hours, maybe 40 hours, because you can split between the two. So anyway, that's something to consider with,
They would probably do even more time than that if you wanted them to. They probably would work a full 60 plus hours a week if you had the time for them.
Yeah, it's interesting. These are Hello Rache basically employs people from the Philippines, and these are typically professionals in the Philippines, like nurses and radiology techs and administrators. They make more money by doing what they do via telemedicine than they do in their home country. That is why they are so willing to do all this. And Dr. Gabal asked, are there issues with retention of the scribes, that is losing them to medical school, as a nurse practitioner school, PA school, et cetera, like you commonly see here in the United States? You've been using it for 4 months, I guess.
Yeah, so I really can't, I haven't lost my scribe yet, my assistant yet, but what you just described about the cost of living differential, that even though the payments might seem trivial in terms of what I'm spending per hour, the $1 goes a lot farther in the Philippines than it goes here, and that's why when people come to the U.S. from the Philippines and send back even part of their paycheck, it goes a long way to support a family, and it goes a long way to support housing. The cost of living is definitely less there. There's still some major issues with poverty there, but a lot of my assistant is a mother. She has a young child and an older child. And I don't see her going back to school anytime soon. She's very happy with what's going on, because I think this allows her to be available for her kids during the daytime by her. And then she works at night by me. And then she gets breaks and rest, and she has help, which is, childcare help there is a lot cheaper than what we're paying for help for virtual assistants here.
Okay, now you said you saw a telemedicine patient at the hospital using Epic. What about in your office? How are you using your Scribe when you see patients via telemedicine in your office? More specifically, what technology do you use so that she could be in the same encounter with you, so that she could help you with the virtual scribing?
Right. So we run a secure Google chat. It's a Google Hangouts meet within my own G Suite. So it's HIPAA compliant, and all the interactions we have are HIPAA compliant, because we keep it within our own network within Google. And then on that same device or computer, or an adjunctive device, maybe an iPad next to it, but usually on the same computer, she can hear the conversation, and even I can share the screen so she can see visually what's going on if we want to. As you know, from a lot of the telemedicine, we've all become pseudo telemedicine experts in the last few months. A lot of the telemedicine is a lot about the talking and not that much about the video. I think the video makes us feel more comfortable that we're having a real interaction with our patients. But like we tell the younger urologists and my residents that I teach, you got to talk to the patient. You got to find out what's going on with them. And if you listen, even just, you stop talking and just listen for a minute or two, you'll learn a lot about what's going on and be able to come up with a much better plan for the patient.
Well, typically the patients, if you listen long enough, they give you the diagnosis, right? And about 90% of the time. That's what I learned in medical school. Well, believe it or not, with telemedicine, I did not share this screenshot, but I was able to do a nice detailed genital examination of a patient. Because of the video quality, it was definitely diagnostic. I would not discount the ability to see what we are when we're talking with our patients when you have a video audio synchronous video audio encounter.
Sure. Patients share a lot of still pictures with me during these encounters or before or after the encounter. And there definitely are some audio visual effects that are helpful. But I think in general, I think that it's really a positive adjunct to the practice. Part of the problem will be is that when we go back to a standard volume of seeing patients at a rapid pace where we're going to try to keep our productivity nice and high by doing procedures and office visits, ultrasounds, what cystoscopies in the office, I'm already starting to feel like I'm getting alerts that patients are on for a video visit, and I have 2 patients in a room and maybe a patient ready for a cystoscopy. So I think that there's going to be some more planning that needs to go on in terms of when you want to do your telemedicine. I know Rich Shore, who's part of our group, urologist in Long Island, he likes to do it after dinner, after going mountain biking. I don't think that's ideal. I'm not such a big fan. I would like to kind of do it either at the beginning of the day or the end of office hours, or if my staff needs if let's say we have a super long day and then we need to kind of have a break to clean equipment or do something in between. Maybe transition where we're doing procedures in the morning and patients in the afternoon, and we need to transition a little bit. I'm often eating at my desk. I don't go out for lunch during the day or anything like that. So I don't need a lot of break time to do that. So I could do some telemedicine then, or at the sort of, I think it'd be kind of relaxing to start the day with telemedicine as well, even though it might not be ideal for the planning of the office, because there's always mail to go through. There's always sort of some, I find that if I try to address everything at the beginning of the day and I got a bunch of patients waiting, it stresses me out. So maybe like a slow transition with some telemedicine in the beginning might be nice.
Yes. And Dr. Betsy says her Hello Rache Scribe starts with her on June 1st. And she is very excited because she had been using an in-person IRL scribe, and now she's transitioning to a virtual scribe. So
I think that's great.
She's a new mom, so I'm not hitting her up yet for her interview opportunity. It would be great to see her perspective from switching from an IRL scribe to a virtual scribe. So much of what we do and the efficiencies with what we do comes down to workflow. And often we don't know that we are not operating the most efficient way possible until someone points that out to us, or until we describe how we do things, and then somebody else says, well, have you thought about doing the other way? For instance, when you mentioned capturing history and updating medications, I can't tell you the last time I did that, because that is all done by my awesome medical assistants. And if I look in my EHR received charts inbox, I have 16 telemedicine visits that's already been pre-screened and the history already populated by my scribes in anticipation of the upcoming telemedicine visits in the next day or two. So much of it comes down to workflow. And I wish, hopefully with the COVID-19 and things are a little bit slow for a lot of us, we have taken the time to slow down and think about how else can we do things more efficiently. And virtual scribes is certainly one of them.
I would agree.
Let's see. Betsy said, Dr. Betsy, I'm ready to come on, John. Give me a month or two to see the difference, but I've got so many plans for my new assistant. So I can't wait to hear what she is going to have him or her do. And Dr. Betsy says, we have days of just telemedicine visits, and then days of 2 procedures and then telemedicine visits, and then 2 procedures and telemedicine visits, so on. So the way I do telemedicine, let's stray off topic here a little bit. The way I do telemedicine is that it's morning block of patients, and then a few telemedicine during lunchtime, and then afternoon block of patients, and then telemedicine the rest of the evening. So, for instance, I think tomorrow I have a ton of telemedicine, like 12 or 13 telemedicine visits after 4:30, and I'll be able to finish that by around 6 something. My staff has scheduled them back to back, and that is in my workflow in my office is the best and the most efficient way to see telemedicine patients instead of going back and forth. How do you do it?
So I think that, in Manhattan, we were really kind of restricted on seeing patients. So we were doing back-to-back telemedicine, and there were days that I was just doing video and telephone calls, and that was it. And now that we're opening up a little bit, so for the last week or two, we can see many more patients in the office. So the beginning and end of my day are in real life or telemedicine, telephone call visits or video visits. And then we kind of pepper them in through the day just because, we're still having some no-shows with regular visits, and the telemedicine visits are a little more reliable. I think
that's interesting.
I will probably block it all off where it's just, okay, so Monday afternoons when I'm out of the OR, I'm going to do some telemedicine visits, and Thursday afternoons. And that's going to be the time when I do it. Because I always find that going to the OR in the morning is much more efficient for me. I always want, if I'm going to go to the OR and do my hobby, which is surgery, which I really enjoy doing, I want to start first. I don't want to wait for other people.
Your expensive hobby. Yep, I know.
Yes.
I hear you.
But on the other hand, if in the afternoon I can do some telemedicine sort of as I'm done with my OR cases, I think that's a nice sort of low overhead day. You think about it, the one real benefit of being in the OR and doing telemedicine is the overhead is lower. You don't need a lot of staff, extra staff that you are paying. If you're in the surgical OR, the surgery suite or surgery center, you're not paying for that staff. And if you're doing telemedicine, you don't need a ton of staff to support you. Well, Hello Rache gives you an inexpensive option so especially someone who's at home one day, let's say they only work part-time and they want to get a little more work done. They could have that support person. Let's say they don't have somebody in their office on Mondays to support them individually. They can go to their practice manager, or they can say, hey, can we get somebody from Hello Rache for me on Mondays? Because I need a little bit of help.
Got it. Now you're talking about practices that don't fully staff their offices when the surgeon is in the operating room. For me, I still have my office pretty much fully staffed when I'm in the OR. So I'm incurring the overhead, but I'm not being maximally productive when I'm in the OR.
Right.
But everybody's different. Some practices will decrease the number of hours by kind of semi-furloughing their staff when they're not in the office. But I keep
or they have other staff, or because you and I both have solo practices, but a lot of people they're in small groups. So someone will not be for you that day; they'll be to the other doctor that day.
Yep, I hear you. And let's see.
Work on authorizations. So
yep, exactly. Dr. Gabal said I try to do the e-visits at the beginning of each half day and then the RL visits at the second half day. And Sarah said we're still only seeing procedure patients in the office who all have to be COVID tested. No e-office visits in the office yet. All telemedicine e-office visits, established office visits. Interesting. Okay. Yeah,
I think that there's no guidelines that I've seen out there that you have to COVID test patients for office procedures unless you're administering oxygen and anesthesia. I have not, since COVID started for my vasectomies and for a couple other procedures like resumes, I did not do any nitrous yet on these patients, just because even though it should be fine, it should be safe, I don't know yet, and I don't want to put anybody at risk.
Yep. Let me go back to what you mentioned about the medical assistants having to do less work with virtual visits, or it kind of insinuated that. I disagree. My medical assistants are still having to prep the charts even before the patient comes in or checks in for their virtual visit. My front desk staff is still having to make sure everything's in order, kind of like what we do with an in real life person. So the work is still being done. We're just not doing the urinalysis, uroflow, post-void residual procedures that we do in the office. But I don't think it's any less work. And certainly for the urologist, for the physician, we are not assuming less risk by conducting a telemedicine visit.
Not at all.
So that is something to keep in mind when payers try to decrease the payment. We are still assuming all the risk, no matter what type of visit that you provide to the patient. Dr. Betsy John is the let's see, with that, when you have the MAs prep your charts, call patients, and ensure that they know how to get online. Yes, my medical assistants, they actually have a huge checklist. Not a huge, but a big checklist of things that they go through with every single telemedicine visit before the patient even logs on. They will check to make sure that they know how to use the Doxy.me platform. They know that they need to turn on their camera. They know to turn on the microphone. And also, when you check into my Doxy waiting area, I have a video that I link to YouTube because it's of the platform the tier that I purchased. You have the ability to create a video that you can link. So I remind my patients to, hey, make sure you're in a quiet area, make sure your camera lens is clean, make sure you're in front of a light source and not have the window behind you. Something like that. And my medical assistants prep the chart and make sure that I'm there for success. All the meds, everything's ready for me. All I have to do is document the history of present illness and also the assessment and plan, and document any physical examination that I can see via telemedicine. So yeah, it's super efficient. And Sarah says the same thing, that her practice does the same thing. Sarah says, agree, so much phone work for the staff with telemedicine visits. Yeah, you are changing from the in real life interview intake to telemedicine, to telephone when we conduct these telemedicine visits. So it's definitely not any easier. The staff is definitely still working. They're moving their mouths a lot and still doing the same documentation.
Right. And I think that also you could have a virtual assistant do all of that work.
Definitely.
And I think that's the key, is that if your current practice can handle the extra telemedicine workflow, instead of saying, well, I'm going to hire a full-time equivalent and pay them health insurance and pay them the going rate in your town, you could Hello Rache or a different service, which I don't know the others, but another service may be the right thing for you. And I don't work for the company. The only reason I got involved with Hello Rache is because of Kelly, and I'm very appreciative for her help and the time she spent with me just talking about how she uses it, because it definitely has sort of become a tool for my practice.
And definitely, for those of you who are interested in the interviews that I did initially with Dr. Grotas and Dr. Casperson regarding virtual assistants or virtual scribes, simply type in a search area in the Thriving Urology Practice Facebook group on your phone. Is typically the first thing way up on top of your screen. On the desktop, it's usually on the left-hand side towards the middle. So search, and you'll be able to find the interviews from those discussions and be able to figure out what we discussed and how Dr. Casperson uses her Scribe. And I can't wait to tap Dr. Betsy, when she has had a little bit more experience regarding her Scribe, transitioning from RL Scribe and virtual Scribe, and hearing about the differences. So Dr. Grotas, what are some of the things that you think could be better in the 4 months that you've had with your current Scribe?
I think that the technology platforms, and I think maybe if I had I don't think the EHR systems are designed for using them remotely within different users. So if I want to type in a note and watch them type in a note, it's not integrated into the system. So I can watch their screen on Google Hangouts while watching my screen, because I have a nice big wide screen and got lots of bandwidth there to take a look at what's going on and look at radiology all at the same time. But it would be nice if someone came up with a real usable interchangeable interface that we could type notes in, and that if other people are typing the notes, we could stay in that same dialog box and watch them type. And then I could click down and put in the prescription. So right now, my Scribe doesn't have prescribing authority, so I do all the prescription, which is not a big deal because that's stuff that's really kind of under my wheelhouse. That's stuff under my license. I'm deciding whether I'm going to use phosphomycin or Levaquin. And you hear all this nonsense. Oh, Scribes are coding. Scribes are this. That's not what should happen. You should not let people take over your license and do work for you. You should let them capture what you're doing so you can be working faster and more efficient. And the nice thing is that when I see a patient and I'm done with the patient, I move on to the next patient, or I'm handling a call or working on some other consulting project. I am not wasting even 10 or 15 extra keystrokes or mouse clicks through the note to populate fields of things that I already said and I already did. But yes, okay, I'm prescribing testosterone. I got to do a couple of mouse clicks for that. Those mouse clicks are my clicks. But things that are not my clicks, I'm paying for help. You're paying for assistance. You don't want to be typing in the medication list. I don't want to type medications in either. They're hard to spell. It's easy to mess them up. And someone else wrote them down already.
Yeah.
So why should you be doing that?
Yep, I hear you.
There's so much else to do.
Yeah. Dr. Betsy asked, have you considered having two virtual assistants, one to do the scribe work and the other to do the prep work? But you already have two MAs, right?
I have a very robust staff already. And I think that if you are understaffed and you have a good relationship with a virtual assistant, you definitely, and you need more help in your office. Option one is you could expand their hours from where you're not there to do some of that work because they already know your workflow. I would maximize one person and then I would get a second person because you want to make sure you have those hours so that you have a dedicated person and you're using them so that they're happy. And if you think about it, they probably want even more than the minimum hours of 30 hours a week. They want 40 plus hours probably a week to maximize the gain for them. And then once you satisfy that, you can probably move on to a second person. But I think that really, if you have an established practice already, you're potentially going to be encroaching on the responsibilities of other people in your office. And you probably have to take a look in the mirror and say, well, am I happy with the person I have at the office? And that's sometimes a tough thing to do. But this is the right time to do it, John, because we're never going to be, over the next few weeks, by July, things are really going to ramp up in terms of in real life interaction where patients are going to be coming out of the woodwork with more pathology, needing more urgent help. And I think that if you want to make change, the best time to make change is when you're slow or you're on vacation.
Oh my gosh, 100%. So true. Because if we didn't have COVID, I would have never learned so many things in doing this type of video production and upping the video game. And I would have not had time to read over the Medicare CMS Interim Final Rule 1744, be able to create the video content. And I really increased my YouTube subscriber count. And there's so many neat opportunities that you can just definitely take advantage. But not everyone needs to be doing that because not everyone is built like the way we are. I am always hungry. I always want to do something more and better. And it just built into me because I think I grew up with so little. And qualifying for subsidized lunches, and when I came to the States, I think that's what made me who I am. I'm always hungry. But anyway, great examples on the virtual scribes.
Great, John. That was a lot of fun. I like that.
All right. Well, I think I've taken up enough of your time. Thank you again so much for sharing your insight on virtual scribes, and I will link Hello Rache in the video description. And what you said is true for me as well. I'm not being paid by Hello Rache. This is not sponsored by Hello Rache. You just happen to use it. I learned about it when Dr. Casperson talked about it, and you received some advertising, and because of, I think, this implied endorsement, I guess, by Dr. Casperson. You reached out, and here we are talking about it 4 months later.
Great.
Hey, thank you. Thank you again. Have a good night. Those of you who are watching, please feel free to leave any comments or questions below. I'm sure Dr. Grotas or I will try to do the research and try to answer your questions. Thank you all so much for watching. Have a good one. Bye-bye.